The next talk for today is about spine care and scoliosis care in children with SMA. The talk is prepared by our neurosurgeon, Dr.Murali Mohan, who leads the neurosurgery department at Salvan Hospital in Spinal.
I'm not Dr. Murali Mohan in any shape or size, but Dr. Murali Mohan has had an emergency spine surgery, believe it or not, so he's had to go away. He's just sent me, that was why I was sitting and working there, he sent me his PowerPoint. But even though I don't know the surgical part, but I know what goes before and after and the technicalities of it, so I'm presenting on his behalf his PowerPoint. So it's basically about the philosophy of care. Many of you have met me or other neurologists who take care of children with spinal muscular atrophy, and curvature of spine, scoliosis, is something that is often present. But there is a particular philosophy of care. Scoliosis that happens outside SMA is very different from scoliosis that happens in SMA. Scoliosis that happens in the pediatric group is even much more different, because children are growing, their spine is not yet grown, so you have to factor in that fact that if you correct it, then are you going to stunt them? What are you going to do when the bone is growing further? All of those things. So there comes the part of growth rods and stuff like that, which are much more complicated. So it is important that the treatment of scoliosis does not limit growth. So the other part is that often we need to brace them, make them wear appropriate bracing, and I think in our midst we have a bracing specialist who will be giving us a talk as well. But because this is a very complicated thing. Bracing is different in cerebral palsy, which has got stiff muscles, as opposed to spinal muscular atrophy, where you have very weak, floppy muscles. So their principle is different. And also, many times when you're bracing them, for the bracing to be effective, there are other things that they'll talk about, that many of these children have breathing difficulties. So if you brace them too tightly, they may be under-breathing. So all of this is factored in. So unlike in normal scoliosis in other children without any problem, anatomy is different. So this is spoken from the perspective of a spine surgeon who has to correct it. Imagine like a carpenter correcting and making it correct. The entire thing is different, the anatomy is different. In SMA, the curve is always progressing, because remember, you and I are sitting and standing erect. They have weakness. So because they have weakness, even gravity is dropping it and making it droop. So that the curve is always progressive. And beyond 40 degrees, 45 degrees, it is a given that it is not only correcting this deformity. So what is the aim of scoliosis surgery? So bracing and deformity surgery, there are two types of ways when you treat scoliosis. So bracing early is very important, because what happens is, in children with SMA, you may not see a scoliosis, you may just see it once. In 3 months, it's just like that happens. By the time you've lost the window of opportunity, if you see a very early curve, for those of you who are parents, what it means is that when your child is sitting, or a young person is sitting, you get a crease in the when you're sitting here, next to your flank. That crease, if there is an asymmetry, that's your first warning. You may not be able to see any curve. If there is an asymmetry between that, that means scoliosis is there. Bring it to the attention of your doctors. We take X-rays, we measure curves, and then we say, okay, let's start bracing. So brace early. So muscles are not going to support the body weight, and this will result in scoliosis. So this is an important surgery, a strategy to postpone surgery. So remember, bracing is not curing the scoliosis. All it is doing is halting it. And growing bones are the ones that are more likely to bend and grow in the wrong way. So age and surgery matters a lot. So we have children who have had scoliosis surgery at 3 and 4 years of age, where we've had no choice. But doing that is not a great idea, because the spine is growing, then every year you have to put magnetic rods, growth stops, all of those things. So we try to avoid that as much as possible. So multiple corrective surgery is not recommended. So brace early. So this is just to give you an idea. Look at this. This is a little baby with SMA who's got scoliosis. Brace. So it can be, normally you see it in adults. Usually teenagers are the ones who get bracing in otherwise normal population. But so that's a normal brace that you see. That is called as a thoracic or lumbar spinal orthosis, TLSO, or a Milwaukee splint. Using anything else, like a belt, many people use the term belt. I have families that come and ask me, Dr. Belt ha. Using a simple belt does not work. It has to be firm, and it has to be used for 14 to 16 hours a day. If you don't use it during that much time, there's no point to it. And the other thing is that you're not literally correcting it. You're only because it's flexible, you're just making it not get worse. That's all you're doing. So from the side, we usually try to engage children in this process and tell them, okay, pick out your favorite color. Because you need their cooperation for this to happen. So, we're not trying to achieve picture perfect radiology. Aim of surgery is avoid restrictive pulmonary disease. Dr. Aileen has already said, these people are, all affected individuals are already suffering from lung problem. And the curve itself is trying to, on one side, squeeze and constrict the lung. That's not what you want. So it's restricting the lung. So you're trying to help the child sit with minimal support. But often what happens with severe scoliosis, sometimes when you correct it, a child who was able to stand might not be able to stand. But that standing is with a lot of effort, it's a trade-off sometimes. So this we often see even when we raise children who have difficulty in walking, they're with great difficulty they're walking, and they're using the center of gravity, pushing themselves forward and then walking. And the scoliosis is also used as a compensatory mechanism for walking. If you correct the scoliosis, they stop walking. But sometimes it is a trade-off and it needs to be discussed and a mutual discussion, this decision needs to be taken in conjunction with the family. So surgical correction of deformity definitely adds years to the child. This is the most important part. Because when we had a camp, in our country where most people do not get treatment, most people do not get any treatment for SMA, what happens is that when we had the camp maybe 3-4 years ago, we saw so many desperately sick people, individuals, who brought literally their patients on a stretcher because they can't even sit. So these people are stuck in their homes. You lose, as human beings, we need to be in touch with other human beings. We need to be talking to other people. If you don't know, you will lose heart and you won't want to, there's nothing to look forward to. So in that way, to keep the social construct, even if you're sitting in the wheelchair, at least if you can go out, that's very important. So surgery is very much a team effort. We have some great surgeons around, but you need lots of backup care. So not all children qualify for surgery. So very stringent pre-surgical evaluation. So most children, when we decide as a team, the medical team, the neurologist, the endocrinologist, the pediatric neurologist, when we decide somebody needs to go for surgery, we prepare them for 1 year. 1 year, sometimes more. Usually the first thing that comes is the pulmonologist input. Make sure they breathe properly. Otherwise, after surgery, we can't get them out without complications. All the respiratory complications. So you need all these people acting to help the child pull through this procedure. So this is from the surgeon's perspective. He puts lots of screws to get better anchorage of the construct, to make it hold. So I've had them tell me stories which make me feel very scared when they say that the bones are not like our bones. The bones are much more fragile. They're much more flexible. So when they try to correct it and put screws, the screws pop out. So they have to make sure it's all staying inside. So longer segments are included in fusion for stability and prevention of progression of curves, and extensive axial derotation. Derotation is it's already rotated, you're derotating it to be tempered, as invariably most of the kids have osteoporosis. They have very fragile bones. You have a wall, you're going to hammer a nail into it, but the wall has to be strong enough. These kids do not have good bones. So too much correction to get a perfect alignment is sometimes not good because it will just cause damage, it will just pull out, and failure of surgery. So under correction is sometimes acceptable. So this is a compromise. This is why it's a team effort. Intraoperatively, neuromonitoring may not always come to our help, but in our team we usually use neuromonitoring to make sure that we're not further damaging the spinal cord. So that's our surgeon, Dr. Murali at surgery. With all the, I don't know about you all, but I also find it, because I'm not a surgeon, I also find it difficult to look at it. So I'm going to go away from that. So this is one of the children that was recently corrected. Now, you may be able to appreciate that this is very, very curved, and it's more than 90 degrees, but it's also slightly rotated. The same after surgery. So the post-surgical care is where we come in. We want them to in-out quickly. Now you want to make sure that the child recovers from anesthesia, ventilation. They can't breathe normally. So many of us adults, walking people also have spine corrections for disc and other things. But when we are ventilated, we can come out easily out of surgery. These children they are hyperventilating, they need more help. Okay. So it needs to be properly timed. So using BiPAP and cough assist can help them overcome surgery quickly. Pain management, very important. This is something that we do very, very judiciously, because if they have a lot of pain, what happens is that they will underbreathe, already problems happen. So we give them very good pain relief. I've had 16-year-olds who tell us, oh, I thought it was going to be painful. This was absolutely fine. So this is, again, big team effort. Early mobilization, sitting up necessary as it influences physiology. So child needs to feel strong. Psychologist is important. Family support. So to conclude, surgery can be postponed by early bracing. Surgery, the aim is to achieve better lung function. So timing of surgery is very important. It's a team effort. Pre-operative, intraoperative, post-operative care is different from usual adolescent idiopathic scoliosis. It needs coordination of multiple specialties. The education of family is very important for setting realistic goals and outcomes in scoliosis surgery and SMA. There is hope of cure, so we should be open in our minds for aggressive treatment. And I conclude with that. So one of the things is that when we give Spinraza and drugs like that, one of the exclusion criteria is if you have scoliosis beyond a certain degree, you're not included, because it becomes technically challenging to give it. So thank you.